Good afternoon, Tech Nation. Welcome to Webinar Wednesday. We are excited to have over 250 registered attendees for today's webinar, which is eligible for 0.1 CE credits from the ACI. Let's get started by giving one lucky attendee a Tech Nation Tour t-shirt for answering this trivia question. Name one of the NFL teams in Missouri. Answer now using the questions feature on your dashboard. While you are answering, I want to invite everyone to join us for the MD Expo, which will bring HTM professionals from across the nation to New England for 3 days of learning, networking, and the latest advances in technology, products, and services. Registration is now open. Receive complimentary admission using the VIP Pass Compliments of Webinar Wednesday found in your webinar workbook. All right, and the winner of our Tech Nation Tour t-shirt is Brandy Tillett. Congratulations, Brandy. The correct answer to our trivia question was the St. Louis Rams or the Kansas City Chiefs. Tech Nation would like to thank our sponsor, Universal Medical. Universal Medical has nurtured a business philosophy founded on offering comprehensive nuclear medicine equipment and services at reduced prices. Universal Medical's products and services include new and reconditioned nuclear imaging systems, quality parts, excellent equipment service, training courses for healthcare technology managers, camera system moves, technical and clinical support, flexible financing options, and more. Visit uni-med.com for more information. Our presenter today is Nick Iwaniw, Vice President of Corporate Quality and Customer Support Services at Universal Medical. Nick, you may begin whenever you are ready.
Thank you very much, and I'd like to thank Tech Nation for actually presenting this today and the opportunity, but also like to thank primarily all of you out there who are taking some time out of your busy schedules to take some time today. And I'm just going to step back a little bit on a lighter side. Well, of course, your trivia question now there is no St. Louis Rams. They are now the Los Angeles Rams. So we've lost that team in Missouri because we're based out of Missouri. We have the Kansas City Chiefs as the other team. So I just want a little correction to have a little fun with that because, and of course, there are some bitter people that we lost that. Okay, thank you very much, everybody. My objectives today are these. And we're gonna go through a lot of different things today, and I hope you can take something away that can support and help you in what you're doing in the hospitals and for the equipment and for the people that are out there in healthcare. I'm going to describe how nuclear medicine contributes to the management of patient diseases, and also in that I'm going to discuss the importance of nuclear medicine in helping the patient and in helping healthcare providers. Thirdly, I'm going to present the terminology that we utilize in nuclear medicine. And what does it mean to you as the HTM, the clinical engineer? I'm going to spend a fair amount of time on these, and I'm going to correlate, I'd like to correlate that information to help you to understand how nuclear medicine works and how the importance of maintaining the equipment. It's an understanding, and I want to help you to hopefully to understand in nuclear medicine what we do for the patient and why it's so important of what you do in maintaining the equipment. And then I'm going to communicate why it is important to perform the regular equipment maintenance and how it contributes to the patient disease outcome. All along, I'm going to be discussing as we go through the clinical, so it's going to kind of be gelled all together a little bit, and I'll spend some time at the end doing that. And then finally, I'd like to explain that significance of a collaborative effort to maintain the equipment quality that results in all of these accurate diagnoses. And that's a collaborative effort that I'll highlight between the engineers and the nuclear medicine department and those people in the department. What is nuclear medicine / molecular imaging? Right now, we know there are many diagnostic techniques that are available. Nuclear medicine provides information about both structure and function, and that's going to be the key is the function part. I'm going to highlight that quite a bit because it highlights the function of virtually every major organ system within the body. It has that ability to characterize and quantify physiology. And that's the important, again, function, physiology. And that's what separates nuclear medicine from many of the other imaging modalities. It makes a diagnosis that comes from the molecular level in the body. That's i.e. the nuclear medicine and now molecular imaging. The Society of Nuclear Medicine has now changed their name to the Society of Nuclear Medicine and Molecular Imaging, and that's the primary driver of nuclear medicine in the industry now. And they've changed that because we deal with the molecule, the cell. Nuclear medicine is a medical specialty that it uses safe, painless, and cost-effective techniques. Again, to image the body, and it also, nuclear medicine treats diseases. And we classify nuclear medicine, like many other the diagnostic procedures, as non-invasive, meaning it's not invasive. It doesn't, we're not going in and hurting the patient, so to speak. For instance, if you're doing a heart catheterization, it's actually a minor surgery. It's actually placing that catheter inside the artery of the person, so it's called an invasive procedure. Most x-rays, most ultrasounds are also non-invasive. Nuclear medicine is unique in that it, again, documents metabolism, function. And that's in contrast to most of the imaging that's done in diagnostic radiology, x-ray, ultrasound, CT, MRI. And they generally provide information about anatomy. Exquisite imaging. All of them add to the portfolio of helping the patient. But nuclear medicine is unique in its ability to help out with function and metabolism. Nuclear medicine, the procedures, they often identify abnormalities very early on in the progression of the disease. That early detection, it allows the disease or helps us to treat those diseases very early in the course of that disease. And that helps to improve prognosis. I'm going to talk a little bit more about prognosis or predicting the outcome for that patient. It uses a very small amount of radioactive, or we call them radiopharmaceuticals, to diagnose diseases. Radiopharmaceuticals, being that it's a radioactive material that's chemically labeled to a normal chemical or radiopharmaceutical. So what it does then is it tracks in the body and goes to a cell or an organ that normally takes that up in the body. Radiopharmaceuticals that are used in nuclear medicine, they emit gamma rays. And these can be detected externally by the gamma/SPECT cameras or the PET cameras. And PET cameras are a part of nuclear medicine, which is positron emission tomography. I'll talk a little bit more about that too in a moment. The cameras, they work in conjunction with computers, like most of what we do in imaging now. And they create images that provide data and information about a specific area or a disease within the body. And in nuclear medicine, the amount of radiation is very minimal. And this has become very, very important in imaging and in hospitals as a whole. Most of you are very probably quite familiar with the new XR29 radiation that monitoring that's involved with CTs. CTs have now have to document the amount of radiation are emitting for every patient. It's kind of a foretell of what's going to happen down the road. So nuclear medicine, being that it is radioactive materials, is working now diligently to reduce that radiation, which is very important to the patient, yet still maintain a diagnosis. There are a multitude of different nuclear medicine procedures that are available. And the development of those radiopharmaceuticals that target the organs and specific diseases, that's what continues to fuel the utilization of nuclear medicine in molecular imaging. It's the radiopharmaceuticals, developing a radiopharmaceutical that will target a cancer, that will target a certain cell in the body so that we can look at that at the molecular level. And I mentioned briefly, in addition to a diagnostic contributions that nuclear medicine offers, it also, a very large growing part of nuclear medicine is the therapeutic or therapy end of nuclear medicine. A lot of the therapy radioactive drugs are being developed to treat cancers, to treat different diseases, and that's become a very growing part of nuclear medicine. But we won't discuss that here, but we'll discuss the imaging part. We live, as you know in medicine, we live in with a world of acronyms. That's how we work in medicine. The nuclear medicine procedures, the equipment, the radiopharmaceuticals, we're inundated with these acronyms. And it's not just nuclear medicine, CT. There you go, CT, computerized tomography. It's an acronym. We're familiar, of course, those in nuclear medicine with SPECT and PET, single photon emission computerized tomography. That's a mouthful. That's why we say SPECT. Some of these are very important that you're going to hear when you speak with your nuclear medicine technologist or they speak to you about what's happening with their equipment. HIDA, for example, that you'll see on this list, the HIDA. That's actually a pharmaceutical, radiopharmaceutical, that's used in imaging the liver and the gallbladder for function. It is a test that's done quite prevalently in nuclear medicine. So you may hear your technologist talk about, well, you know, my HIDA scan doesn't look very well. The resolution on my HIDA scan isn't good. My GBEF, as you see on here, gallbladder ejection fraction, is not coming out well. Well, if you look at what you'll do is you'll look at the technologists with the deer in the headlights look, what are you talking about? We hope that from this today, some of these terminology you can take with you so you at least have an understanding that you can work together and understand what we have our own language in nuclear medicine, what we're talking about, so that to help you understand and maybe helping to work with the equipment more. We have MVP, that is actually an agent that is used to image the bones in nuclear medicine. MUGA is a MUGA, it's multi-gated acquisition. It's actually using a gate, and then we can image the organs in the body, actually image the heart and get the blood flow and how well the heart is pumping. Used a lot in cancer patients, and I'll talk just briefly on that. CCK, we mentioned HIDA, GBEF. They are the same procedure, but the CCK is a non-radioactive pharmaceutical. So cholecystokinin or syncoide, that's used to contract the gallbladder to see how the gallbladder is functioning. MPI, we're going to talk about that. That's myocardial perfusion imaging. And we'll talk more. MAA is just an agent we use for lung imaging. MAG3 is for renal kidney imaging. FDG, that is an agent that is used in PET imaging primarily. Fluorodeoxyglucose. It's labeled to radioactive fluorine, F18. And this has become, as most of you probably may be aware of, PET scanning with FDG is used a lot in cancer diagnosis. Cancer cells. Cancer cells are overactive cells in the body. Overactive cells use sugar, glucose. It's radioactive sugar. Radioactive sugar goes to these cancer cells so we can tell where those cancers are in the body using a PET scanner. And those that work in nuclear medicine know that MCI is the acronym for millicuries, which is a standard unit used in the amount of radioactive material that we use in millicuries. And why should you care about this? Again, it's understanding what maybe the technologists are talking about to help you to understand about nuclear medicine more in helping to work on the equipment. Diagnosing diseases. We help the patients and the healthcare team by diagnosing diseases, again, that occur in almost every organ system in the body, depending on what radiopharmaceutical we can inject. I talked briefly. You see the top of the list, heart disease and cancer. The number 1 and the number 2 killers in the country and in the world. And it's interesting to note that cancer now, very shortly, it's predicted might overcome heart disease as the number 1 killer. And it's not so much that cancer is growing, but because of our really focus on heart disease, helping patients, medicines that we're doing, and helping out patients early in the diagnostic tools we have, heart disease is actually reducing, and actually we're having less heart disease, which is a really good thing. But we impact in nuclear medicine the #1 and the #2 killers in the world. Gated SPECT, MPI studies, we talked about MPI, myocardial perfusion imaging in the MUGA. That's for diagnosing the heart. Cancer, we do the bone scans. And I'm going to show some pictures, and of course, a little bit later here, that will help out to understand this better. We do bone scans to diagnose bone cancers. We're doing breast imaging. Everybody knows mammography is kind of the standard. It is the standard for diagnosing breast cancers. It's an anatomic x-ray, of course, looking at the breast. However, those patients that have a dense breast, it's hard to diagnose. And a lot of times we get what's false positive. It shows something on the breast in the mammography, but is it really cancer, or what really is it? With nuclear medicine, we can inject a radioactive material that actually localizes in the tumor. And that is used in adjunct to the mammography to determine whether is it a tumor in dense breast especially, or is it not a tumor. And we also, a procedure we're doing a lot more of, I have listed here, is sentinel node imaging. What is sentinel node? It's actually related to breast imaging. Breast imaging and then breast cancer. When we're having a patient has breast cancer, it spreads or metastasizes through the body, primarily through the lymph system. We have the lymph system and we have the blood supply. Those are your circulating systems in your body. What breast cancer does in spreading, it spreads by the lymph system. So what we'll do then is we inject the patient, or actually the doctor injects the patient around in the breast area. And we inject it under the skin, which follows the lymph. So that follows the lymph to a node, i.e. the sentinel node. The sentinel node is the first lymph node in the lymph system. So what we can do with the radioactive material is localize that sentinel node, and then in surgery, the physician can go in, find that node, biopsy it. If that node has cancer in it, we know it's at least spread that far and maybe beyond. If that node does not have cancer, then my prognosis or the spreading of the cancer, of the breast cancer, becomes a lot less likely and is much better prognosis. So an important study. We do some liver scanning, not as much anymore. The liver gallbladder, we talked briefly about that, the HIDA, the GBEF. I'm going to show some pictures on that. And then also gastric emptying is a study that we do in nuclear medicine of the stomach. And it's really labeling a radioactive material to some eggs. The patient eats it, and we determine how well the stomach is functioning. It's become more and more of a procedure that's done in nuclear medicine. The lung scan for the lung ventilation and perfusion, not done so much anymore to determine whether there's a clot in the lung. CT does this most of the time now. However, patients that can't tolerate contrast or are allergic to contrast of CT, we still do the lung scan, and that's an important study because a clot in the lung can kill the patient. We do a lot of kidney studies. We can determine diseases in the kidneys. The thyroid was one of the first studies that we do in nuclear medicine to determine how the thyroid is functioning, and thyroid controls your metabolism in your body. And we also can look at cancers of the thyroid using radioactive iodine. The brain imaging used to be a long time ago when I first started in nuclear medicine, was one of the big 3 imaging modalities of nuclear medicine: brain, liver, and bone. Well, brain imaging kind of went away in nuclear medicine because we have CT and MRI, excellent tools for brain imaging. However, in recent years, with Alzheimer's disease and, again, function, we are doing PET imaging to diagnose Alzheimer's disease because we can see the cell level of the brain. And that has been a while to catch on because Alzheimer's disease, well, we can diagnose Alzheimer's disease with PET imaging long before the symptoms that the patient actually sees symptoms. But there's no cure for Alzheimer's disease. However, in our PET imaging, we can determine whether is it Alzheimer's disease or maybe another type of dementia, and that's important. And Parkinson's disease in nuclear medicine, a real high-profile disease in our society. Michael J. Fox, Muhammad Ali, very high profile. Parkinson's disease, of course, what we can do in nuclear medicine, we can inject a radioactive material and we can determine whether a patient has Parkinson's disease or whether they have a Parkinson's type syndrome. And brain death studies is still done in nuclear medicine. Unfortunately, it's a study when a patient is legally dead, brain dead. They do not have blood supply to the internal carotids of the brain, and that's a determination for brain death. And the nuclear medicine study determines that after they do a brain death protocol, which is a series of squirting water in the ears, EEG, a whole lot of protocol, but the last test is whether they have blood supply to the internal carotids of the brain. If they don't, then they legally can be removed from a life support system, and that's important, unfortunately, in a lot of situations to give some closure to the families. But it also is important in that we're able to harvest organs that can help other patients. So it determines brain death. And it's interesting, a little tidbit here. It's interesting in brain death that if a patient in nuclear medicine, if they come up with no blood supply to the brain and they're legally dead, this is just a little sidebar. If a patient has a barbiturate overdose, they actually can come alive in about 48 hours. So we can't really pull the life support from them. We have to wait 48 hours to determine. It's kind of interesting to determine whether they may all of a sudden show that they've got blood supply. It's kind of a unique situation. And finally, PTSD, TBI, post-traumatic stress disorder, traumatic brain injury. High profile now with our soldiers coming back from battle, veterans coming back with traumatic brain injury. With nuclear medicine brain imaging, we can define or help define the determination between those two. Become very important. Just briefly, we use the radionuclides that are tagged to the pharmaceuticals. Technetium-99M was the primary one we use in diagnosis because it has a half-life, and I won't get into some of the physics here. It has a 6-hour half-life, and that means the radioactive material in 6 hours decays halfway down, but I won't talk too much about that. And it has one energy. We use that a lot. We use cobalt-57, or you use cobalt-57, we all do, and that's one that we use for actually calibrating and determining how our systems are running. Gallium, indium, all these agents, you see their half-lives. Some of them are a little longer. Xenon, which is an agent we use, actually a gas that we use for lung imaging. And then the iodines, the 123 and the 131. And these are agents a little bit that are used for diagnosing. The I-131 at 8 days, it's used to actually treat cancers and overactive thyroids. And finally, the fluorine-18 for cancer, FDG, in PET imaging, 110 minutes. Cyclotron produced, short half-life, but very valuable. Now, you're probably overwhelmed with, oh my gosh, what is all this? We'll step back a moment. We look at collimation. Gamma cameras, real briefly, gamma rays go in all directions and from the patient. As we come out of the patient, when we come out of the patient, these gamma cameras, this is our camera, they go in all directions. And I know most of you know what all this is about, so I'll be brief. So we put a collimator on with lead scepter, bore, all that, and all these gamma rays that come out of the body, we can define what comes out of here is registered here on the camera, so it creates our image. So we actually see an image via really getting rid of those radioactive emissions that we don't need. Myocardial perfusion imaging. I'll spend a little bit of this, and this is really 50% of the nuclear medicine procedures that are performed are still this myocardial perfusion imaging. And I want to highlight this because you're going to hear a lot about this, MPIs, SPECT imaging, rest stress, myocardial. You'll hear this because it's used all the time. And the importance of this scan is its ability to not only diagnose, but also the prognostic value of it. This is our data that we get from the camera. Each of the little segments that we do, just like a CT, we go around the patient to create all this image. This is the heart right here. You see the ventricle here. And this is, it's eliminated in the bowel. But these little donuts, as we call them, up here, and this donut here, this actual bright spot that I'm highlighting is actually the heart muscle. It's the blood supply and the heart muscle, and then the little spot in the middle is actually where the blood supply is. So we have the heart muscle, and this is actually when the patient is exercised, and this is the patient when they're resting, stressed and rest, and this is a different angle of the heart when they're exercised and resting, exercise and resting. What's the importance of that? When the patient is resting, and let's take this to a heart catheterization. This is the difference in anatomy versus function and physiology. When a patient gets a heart cath, and most of us know somebody that's had a heart cath, you will hear terms such as 85% block of an artery, of a coronary artery. Okay, I've got 85% of that coronary artery is blocked. That's significant. However, anatomically, coronary arteries are like noses. Everybody's nose is different. Everybody's artery is different. For instance, to use an analogy, if I have an 85% block of an artery, that's the diameter of, let's say, a pencil, versus 85% block of an artery that's the diameter of your thumb. Now, 85% of the block of an artery of a pencil is not going to let much blood through. 85% block of an artery that's in the thumb is going to let a little bit more blood supply. So how much blood supply is getting to the muscle is actually what we're seeing on these images. So if they're at rest and the heart is normal, and at stress, they're not getting enough blood there because the artery's closed off, that muscle starts to not function, so that muscle will not fill up. That is an indicator that that patient is on the way to maybe having a heart attack. So we're going to have to either do a catheter or do something, heart cath or stent or something to fix that. This study, the value of it is prognosis. How will that patient outcome happen? If I inject the patient, and this study is normal, the camera is calibrated right, it's repaired correctly, and the technologist does it correctly. If this is normal, the doctor can tell that patient and say that in the next year, you're going to have a less than 1% chance of a cardiac episode. That's reassuring to the patient. That's the importance, the prognosis of this study. We could also see ejection fraction by gating the patient. We can put a gate on the patient and get the heart beating and actually see how well the heart is contracting. So in addition to the blood supply to the muscle, we can see the heart contracting. A multifaceted test. We talked about the gallbladder. The gallbladder, HIDA, gallbladder ejection fraction. Here's your liver, that agent we use. See that bright spot? That's your gallbladder filling up. Well, the gallbladder's purpose is to break down fat. Well, what happens, of course, when we eat a big meal at Thanksgiving, if our gallbladder isn't functioning correctly, well, we have gallbladder disease. So we'll get an ultrasound. We see if there's stones, or we see if there's what's called sludge. Okay, I got stones, I got a problem with the gallbladder. This tells me how well the gallbladder is functioning. It goes out the ducts and it empties out, which you'll see, into the small intestine. So that tells us over like a dynamic picture how well the gallbladder is functioning. Take note, we see the gallbladder really bright here. This image here is a series of images where right here would be the gallbladder. We don't see it. These are the ducts coming out of the gallbladder. We don't see the gallbladder. That is a situation where if the patient, we don't see the gallbladder, it's an acute situation or something that now we have to take that patient to surgery right away. Again, function of the gallbladder. Bone imaging, we inject a radioactive material. We can do SPECT imaging, of the bone. Notice this real bright spot in the lower, this is the lower spine. This is a study we use a lot, not for cancer so much, but for non-cancerous backache poems. This is a study early on in the disease that we can detect a bone abnormality that maybe not show up on X-ray. Bone cancer. We have the ability with our systems to do total body imaging. This is the bone image. This is the front of the patient, anterior. This is the back of the patient. Bone imaging. Notice all of these bright spots that we see. All of those bright spots, that's metastasis of cancer. It's cancer that's spread to the bone. Prostate cancer, lung cancer, and breast cancer are notorious for spreading to the bone. And because we're looking at the cells of the bone, we can see a cancer that spread to the bone very early in the disease to maybe address this. And that's why it's important. If our mechanicals aren't working well, and most of these cameras run on a table and run the patient total body to create the total body. If we haven't calibrated our mechanicals, or if our imaging, our resolution isn't done well enough, and we can't make this diagnosis, the doctor and all of us cannot help that patient out. And this is very important in the fact that, as an example, and in nuclear medicine, and any of us that work in medicine that deal with cancer patients, they come back all the time because we're doing imaging to see how well are we impacting the cancer. It's important from the fact that, really important in that we get to know these patients. We get to know their families. So when you're fixing those equipment and doing that, these patients are going through a fair amount of anxiety, a lot of anxiety in different stages. I give an example of a patient I knew as her name was Katie. We'll call her Katie. She had breast cancer. Her bone cancer spreading to bone, metastasized to her lymph system, looked somewhat like this. She had chemo, radiation. She came back and it was gone. Came back again about every 6 months. We did a scan. We scanned her to see how well she was doing, and it came back. And that's not a good prognosis if the cancer starts coming back to the bone. Her husband died of brain cancer. She was a phenomenal person. She was so positive. Her on life, she finally succumbed to the cancer. It killed her. To make those diagnoses is really important. It's important of the family. Real briefly, this is just a lung scan. These are the lungs. This is the air, the radioactive air, radioactive gas in the lungs. This is the perfusion. We determine whether there's a clot. And all these little blots here, that's a clot. Highlighting again, nuclear medicine, we do a lot in nuclear medicine for the studies. You know here, the gastric studies, MUGA studies, thyroid studies, the SPECT, GI bleeding. We can determine whether there's a bleed in the gastrointestinal tract. Parathyroid, we can image the parathyroid gland, which is the gland that controls the calcium in your body, to see whether there's tumors in the parathyroid. We talked about SPECT brain imaging, sentinel node, gallium and indium that are used to localize infections in the body. We can't find the infection. So we label the leukocytes or the white cells, and that goes to infection. So we can find the infection in the body by using radioactive materials. When we're dealing with scheduling maintenance, there's a time factor. Nuclear medicine studies take time. They are time-consuming, and this we have to take into consideration when we're scheduling equipment maintenance. For instance, some of the common studies. If we're doing a high-def gallbladder ejection fraction, it is approximately an hour and a half. So if you have to do some routine maintenance, or if you have to perform some type of repair in the camera's functioning, and the technologist tells you, well, I've got to hide a scan. So what does that mean to you? Well, you're going to know that HIDA scan, I'm going to start a HIDA scan. It's going to be an hour-and-a-half study probably. A total body bone scan, we inject the patient. We wait 3 hours. And then we have to bring the patient back because it takes that long for it to accumulate in the bone. And then we scan the patient, either total body and then different images. It could take half an hour to an hour. So when you're timing that, this is important to know these times. The whole process of the rest and the stress, the cardiac, the MPI study, it is a series of injections at rest, scanning, and then waiting, and then stressing the patient or exercising the patient, and then injecting, and then waiting and scanning again. And that whole process is 3 hours. So that's important as you're trying to judge your schedule on when you can get on the camera in order to actually work on it. Also, the gastric emptying study, if it's a dynamic study, it's an hour-and-a-half study. If we're going to do the static study or images over a period of time, and this is recommended by the Society of Nuclear Medicine and Molecular Imaging, that it's an image every 30 minutes, an hour, 2 hours, and 4 hours. The whole process is 4 hours. Again, time-consuming. If knowing, understanding some of this will help you when you're trying to schedule time with the technologists, and they should make you aware of how long it's going to take. But when you hear these terminologies, you'll understand how long you may have in order before you can get on that camera. I just want to highlight a little bit here briefly the roles. As we talked about, your role in equipment maintenance, and you know your role, is in order to make accurate diagnoses, image quality and camera system reliability are really quite vital. And that a proactive approach to image quality and system reliability, it's of course not only recommended, but it's advised. That approach is continued upon. We have to adhere to a consistent and a very thorough PM maintenance program. Doing PM is so vitally important. And the effect of a PM program requires that you as the engineer look for items that may cause patient harm, downtime, or et cetera, or in the near future, that attention of these potential problems, if they aren't addressed, the system's going to go down. So vitally important for you as the engineers to perform thorough, accurate, preventative maintenance on the cameras and computers. Also in your roles, the patient safety device, really highly important. Collision sensors, the e-stops that help to stop the camera in case of an emergency, and the collision sensors that, of course, if the patient gets too close to the patient and starts to press on the patient, it'll stop the camera from moving. Making sure that these are functioning is vitally important. And then also being aware of the mechanical and the electrical components. Lubrication. There's a lot of gears, as you know better than I, all the gears that are on. And to make sure that the proper lubrication so that these function normally when the table is moving to do that total body scan that we're doing, or the spec in rotating around the patient. It's important to do lubrication, and not just do lubrication where you're lubricating on top of lubrication, but the probably best that I've heard and recommended by the engineers is to remove all of the lubrication, or as much as possible, and put on fresh and new lubrication or new grease. And then, of course, most importantly, and as much as important, is the image quality. It's so crucial in making an accurate diagnosis. And if the PM tubes or the electronics drift and power supplies drift, these calibrations, tuning of these components are very important to alleviate image artifacts that might occur, both large and small. This is important from the technologist, our standpoint. This is important for us to have a role, and it's important, hopefully, I would encourage all of you to coach your technologists. When I come in and I do clinical work with a technologist, on the side, I'm always asking them, making them or coaching them to be aware of their equipment, because they are the eyes and ears of that equipment. They're working with it all the time. They need to be a part of the team and of making sure that get accurate diagnosis with equipment. They need to perform their daily, weekly, and monthly camera quality control for image quality. And a lot of this is governed by regulations, but if they get lazy, they can miss something, or they can miss something and not help you out as well and the patient. If the image quality degradation occurs, it is their role and their responsibility to document and report these discrepancies as soon as possible so that you can take action. The mechanical operations, they should be aware of grinding, noises, so that they be aware of that so that they can inform you about it to repair it. And if an error occurs, that technologists should be coached and taught to document these messages. And so that you can do accurate troubleshooting. In a lot of them now, we can go on the systems. You can go on the systems and the computers, and you can do log files and find out what's going on with the system. But a lot of the older systems, those messages and those error messages are important for them to document and coach them to do that. And then to bring this all together as a collaboration, working in collaboration with each other, the clinical engineering department and the nuclear medicine department, it makes for a more effective way of making sure that our imaging equipment and the accessories remain functional. And this helps the patients and the physicians, the healthcare team, in providing good care. Be aware of not just the camera, the UPS, fans. If fans make noise, for instance, on a camera like a CardioMD or a C-cam, a small cardiac camera, there's a small little fan that provides air to that, if you know, they're called the EDC board. That board is really expensive. The fan goes, the board goes. Well, if you change out an inexpensive fan, it helps that board to stay alive. So again, being preventative, change out fans. Be sure on your gating devices, those little wires, those are really, they're putting them on and off all the time. I always advise nuclear medicine to order a second set just in case. Without that, they can't get the ejection fraction. Backing up all of your corrections and software is extremely important, and that's important. And then, of course, becoming more important now are the monitors. Being aware of the monitors. Now, those that are in the hospital, in the monitors. Previously, mammography was really regulated very much, and the doctors read off the monitors. The physicists would have to check those monitors had to meet certain quality standards. Now, in those for the Joint Commission, who are under the Joint Commission, those monitors in nuclear medicine, in CT, and in PET all have to be checked by a physicist once a year. That's a luminance test to see, make sure the brightness is correct. And also for resolution. Some of you, if you remember nuclear medicine way back, what's called a SMPTE pattern. I always advise the technologists, and if they have a SMPTE pattern on their system, never erase that off, because that is what's used as an image to determine the resolution. And now that's very important to be aware of. In summary, nuclear medicine and its ability to image at that molecular level is a valuable contributor to the portfolio of all the diagnostic tools that diagnose and also that we treat diseases. Proper PMs and repair maintenance of the nuclear medicine equipment is invaluable. And these systems, it's invaluable for these systems to adequately provide that service. Clinical engineers who possess this basic understanding about nuclear medicine to help you work with the technologists and develop a collaborative team effort with nuclear medicine team that can help to contribute greatly to achieving those optimum equipment maintenance, working together, understanding, and I hope we can draw a little bit of understanding, a lot of clinical stuff, I know. And then, again, can't stress enough the regular quality checks and maintenance, how that greatly enhances your accurate and maintaining and fixing that equipment means so much more, because fixing that equipment is really the starting point and the foundation for fixing a patient and a family. You know, all of us, you may think, you know, a lot of times in engineering you're fixing that equipment. You know, fixing that equipment helps the nuclear medicine department, helps the physician to make a difference in someone's life. I'd like to thank all of you for being with us today. Thank you to TechNation for putting this on. I hope we can draw something, take something with you today. And again, thank you very much.
Hi, Nick. Thank you. That was a great presentation. We've had a couple of questions come through throughout your presentation. So if you're ready, we'd like to go ahead and start with the questions and answer section. A reminder to all attendees that you can feel free to submit your questions now using the dashboard question feature. Okay, Nick. So the first question here. How often do you recommend performing routine preventative maintenance?
Well, that's a good question, and really, it's a good question because of the fact that, you know, generally speaking, preventative maintenance, a lot of that is kind of governed, you know, about whatever regulatory agency you're under, you know, ACR, you know, they have recommendations, and a lot of the recommendations, of course, is geared by what the OEM dictates, and that's kind of the standard of what they dictate. But most of them generally, it's every 6 months. It's usually this kind of a standard for performing routine preventative maintenance and documenting routine preventative maintenance.
Great. Okay, when performing a PM, is there anything in particular the engineer should be aware of?
Probably what's most important, we talked about the, you know, the time it takes for the procedures, and I alluded to that, and being aware of scheduling it. And most of you probably know, but one thing that always is a highlight, because when you come in and you're working on those detectors, and most of the time, of course, all the time when you're working on the detectors, we take that collimator off. When we take that collimator off, we have just the crystal there. And it's very sensitive to all the radiation. It's really important to be sure that there's not a radioactive source that can be out there. A radioactive source that maybe a patient walking around is still radioactive, or a CT scanner in close area, or maybe the technologist might have a source sitting out, because that background will affect your, as you know, will affect when you're trying to calibrate those detectors.
Excellent, thank you. Another question that came in reference to image quality, in what way should or can the clinical engineer prepare for ACR accreditation?
Well, yeah, I kind of mentioned briefly Joint Commission, but ACR, a lot of the hospitals are ACR, American College of Radiology. Another acronym, of course, American College of Radiology. They are kind of accredited for radiology departments. And what I advise, and I found, and this is real important working with the technologists or nuclear medicine for the engineers out there, is that when ACR accreditation is coming in, ACR is really strong on image quality. They do a SPECT phantom if you're doing SPECT. Image quality in floods, bar phantoms, resolution is real important. I really encourage strongly that when we know that the schedule of the ACR accreditation is happening, to have the engineers come in and do a complete tune on the camera, so that camera is performing pristine as far as resolution and uniformity, so that when we submit our images to the ACR, we have a high likelihood that we're going to pass, you know, with no problem.
Okay, great. Another question that came through. Do the images in your presentation represent the best in terms of clarity and sharpness?
No, not necessarily. That's a good question. I use those. Of course, that total body bone scan was, you know, of course, you see the skeleton real well. One thing you see in a lot of these patients is that you see a lot of soft tissue if they're big, you know, really large, you know, and that's a good image. But in a patient, one thing you'll note that you'll find that a patient that has cancer, A lot of that radioactive material goes there, so it makes actually the scan look better. But you know, that cardiac scan I showed you, that's kind of standard, you know. But also remember, not only does the equipment have to work well, but the technologist needs to perform the study well. And if they don't perform the study well, those images won't look good. So it's a combination of both the image quality and the good resolution and uniformity of that camera. I hope that answers that question.
I think so. Another one that came through is specialized equipment necessary for PMs and repairs?
Sometimes yes, yes, there are certain things, yes it is. Sometimes you'll need, for instance, there might be a lead page or certain tapes in that, and not being an engineer, I've seen some of this, but there may be, of course, most of you know you've got your meters and all that to check your power supplies and all that. Primarily it's being sure that, of course, and that's a good question, the fact that not so much equipment, that the technologist orders you the adequate radioactive material so you can calibrate the systems. And at the time, that's why timing of knowing that when you can get on the camera, for instance, for a PM is important, because if, okay, you're scheduled to do the PM at 9 o'clock in the morning, and all of a sudden they're doing a HIDA scan that's going to take 2 hours. They order a radioactive material for you to calibrate the system for 9 o'clock. Well, after 2 hours with a 6-hour half-life, you're already losing close to half of that. So it can hinder what you're actually doing, actually in performing your uniformity corrections and your resolution and your calibrations. But for equipment, you know, it's usually some of the tools that you need for electronics and mechanicals.
Okay, Nick, I think that wraps up about all the questions that we had come through. Reminder to attendees that Nick's contact information is on the screen, so you're welcome to contact him directly. We'd like to say thank you to Nick, of course, for today's presentation, and thank you to our sponsor, Universal Medical. One lucky attendee will win lunch for their entire department. You can find out details in the post-webinar survey that you'll be receiving shortly. You must complete the survey to obtain your certificate of attendance. If you do not see the survey, please email us at webinar@mdpublishing.com. Thanks again, everyone. Till next time.